So we are live now.
Okay, thank you.
काल टाइम पर काल हेलो बोलो हेलो
Sir,
यस
Good evening, sir.
गुड इवनिंग
Go. Hello.
good evening, Dr. Vijay.
Dr. Madhuri's phone laptop has switched off. Just she will restart in 1 minute, sir.
No problem, no problem. Please.
सब तैयार
good things you can hear them. If some of the I so
please
one yeah, please go.
Recording in progress. Recording in progress. Recording in progress. Recording in progress.
Turn up light. No, arguing, no arguing. I think I have it. Hello.
Sir,
Are we starting?
yeah, within 1 minute, sir.
Okay,
8:05 we will start, sir.
no problem. Lama. Busy.
Sir, shall we start?
Please, is Dr. Lakshmi around?
Sir, he is in the ICU. He will join within 10 minutes, sir.
Okay,
So shall I start?
please, I'm
you.
just waiting.
Thank you, thank you. Ladies and gentlemen, and esteemed colleague and all the attendees, welcome to all for the 44th episode of The Secret of Neurology. it's an honor to have you all join us today for yet another enlightening session. Our distinguished guests for today's webinar are from Apollo Hospital, Chennai, featuring the experts Dr. Arul and the esteemed team led by Dr. Vijay Shankar. As an embark on this session, it's a moment of pride to acknowledge that we are steadily approaching the completion of the fourth year journey, all thanks to invaluable guidance of our course director, Dr. Sudhir Shah sir, and the Dr. Lakshmi Narasimhan sir. Let's dive into the depth of the neurology with enthusiasm and dedication as we continue to unveil the secret of this neurology, secret of neurology. And it's pride to introduce our course director, Dr. Sudhir Shah sir. Dr. Sudhir Shah sir, he is Padam Shri awarded, and Dr. Sudhir Shah sir is a professor and HOD from Shrimati NHL MMC SVP IMSR Ahmedabad, Director of Neurosciences, Sterling Hospital, Ahmedabad. And sir has so many books. He is the author of 6 books on neurology, public education, and several publications in states and national and international journal. Sir is the consultant neurologist to the Honorable Governor of Gujarat, and sir is having an interest in stroke, neurodegenerative disease, and in epilepsy. Further to this, it's honored to introduce our second course director, Dr. Lakshmi Narasimhan sir, Director and Professor, Department of Neurology, Shri Ramchandra Institute of Higher Education and Research, Chennai. Sir has achieved the as far as Palliative C Advisor for IN 2007 A.B. Baker Award for Global Best Teacher of the American Academy of Neurology. And sir has achieved Best Paper Award of the American Academy of Neurology and American Indian Neurologist Association 2009. And so many other awards sir has achieved. And the contribution of Dr. Lakshmi Narasimhan sir, that he has given the 3-term executive member in the Indian Academy of Neurology and CME convener in the Indian Academy of Neurology, and successfully organized 7 consecutive clinical neurology science program for All India DM postgraduate by the name of SHINE right from 2010 to 2017. So it's really an honor to introduce both the course director. Now I am handing over the session to Dr. Sudhir Shah sir to introduce our today's guest. Sir, over to you, sir.
Thank you and welcome to all delegates over this 44th episode of Secrets of Neurology, Knowledge Feast for all neurologists. I am very grateful that Apollo Hospital Chennai has accepted our invitation and have agreed to discuss a wonderful case, a tale of unusual case of amnesia with us, and I'm sure it will give a lot of insights in different aspects of cognitive neurology. Now, my sincere thanks to all other previous 43 institutes and speakers and heads of departments who have delivered their wonderful case sessions and enlightened all of us. At the same time, I am so grateful to all delegates for putting trust in us, and even on the 44th consecutive monthly episode, you see the consistency, the quality, the type of material that is discussed here, that all the delegates are always like to participate. Thankful to all the delegates, and some of the delegates, I must mention again that they are not only from India but from different countries from abroad, from Europe, America, Thailand, Sri Lanka, and nearby other countries also, from far and near different countries. So we are very thankful to all of you. I must also acknowledge great contribution of my co-course director, Dr. Lakshmi Narasimhan, for his untiring efforts to make this program more and more successful. I am very grateful to Team Intas Global Cell division headed by Mr. Arun Chadda, who has given logistic support and wonderful networking and infrastructure for this flawless program. So thanks to him, Dr. Manoj Kumar, Dr. Swati, all other doctors who are part of the team. So with that, I would like to mention that today, the case of today's discussion is a kind of unusual amnestic syndrome, a tale of case of unusual amnesia, and that would be taken by Dr. A.N.S. Madhuri. Madhuri is a third-year DNB neurology resident at Apollo Hospital, Chennai. She has done her MBBS from Maharaja Institute of Medical Sciences, Vizianagaram, and MD from Kattudi Medical College, Guntur. Then the case would be further given momentum by Dr. S. Muthukani, who would do investigative aspect of the case. So again, he is a winner of International Scholarship Award at American Academy of Neurology Annual Meet Los Angeles in 2018. He is a consultant neurologist and epileptologist at Apollo Hospital, Chennai. He has received All India Gold Medal for DNB Neurology in June 2020 session from Honorable Health Minister of India. He started the epilepsy surgery program, including long-term video monitoring of EEG for the first time in South Tamil Nadu, and he has published several papers in national and international journals. So, as you can understand, his interests are drug-resistant epilepsy, pediatric epilepsy, and of course, epilepsy surgery. The case would be further taken by Dr. Vijay Shankar and Selvasan. Vijay Shankar, as you know, is a senior consultant neurologist, movement disorder DBS specialist, famous in India. He is also from the same hospital, Apollo Hospital. He is DM neurology. He has a fellowship in movement disorder DBS. He has fellowship in movement disorder Toronto. He has a fellowship in European Board of Neurology. He had Silver Medal Award in Video Challenge 21st International Congress of PD and MDS at Canada. He was member of the Communication Oversight Committee, IPMDS, and member of NPH Ataxia and Rare Movement Disorder Study Group. Naturally, the area of interest are movement disorders, ataxia, and DBS. Next one. Next slide, please. Dr. Arun Selvan would do a lot of discussion. So he and Professor Vijay Shankar will discuss and then conclude and give summary. So he's a senior consultant neurologist, Apollo Hospital, Greens Road, Chennai. With that, I request Dr. Selvan and Dr. Vijay Shankar to take over. Thank you very much once again to all, one and all. Thank you. Dr. Lakshmi is here. Dr. Lakshmi, welcome, please.
Yes, sir. Sir, in fact, I wanted to thank the entire Apollo team headed by Professor Arun Selvan, Muthukani, and they are the pillars of the Madras Apollo, sir. All the three of them, each one of them have a lot of laurels, and I sincerely thank them for accepting this our invitation. Thank you so much. Please go ahead, Dr. Arun Selvan. Thank you.
You are a true jeweler, Dr. Lakshmi, and you are able to find the jewels and different precious stones from deep seas and different
all your blessings, sir. Thank you so much for your blessings, sir. Thank you, sir.
Thank you. Thank you very much. Take care. Thank you.
Thank you, Professor Sudhir Shah, and Professor Lakshmi Narasimhan for the generous introductions. So now we will go ahead with the presentation. This young adult with rapidly worsening cognitive behavioral problems. I now request Dr. Madhuri Sharma to start the presentation.
Thank you, sir. Good evening, everyone. I'm Dr. Madhuri. This is a tale of rapidly progressive neurocognitive decline. These are my patient's demographic details. His age is 21 years and he is a male patient and his formal education was 12th standard and he is from Mauritius. The informant was his mother. And the chief complaints were a 21-year-old male patient was brought with complaints of behavioral changes since May 2023 and difficulty in walking since August 2023 and memory loss since October 2023. Our patient was normal before May 2023 and was observed to be tired and sleepy and having low energy. Despite the above symptoms, he managed to go to university in UK for his higher education in June 2023. And in June 2023, when he went to UK for his higher education, he was disoriented and confused in the university. When he went to report in the university, he was given 1 year off to get his health issues checked. And in July 2023, after returning home from UK, he was observed to be less interested in his daily activities like playing in the PlayStation, meeting his friends, and he also stopped watching TV. And in August 2023, he was observed to have difficulty in walking in the form of slowness while he was walking. And he also complained of had stiffness of legs. And there is no history of twitching or wasting of muscles. And he was able to negotiate through the narrow pathways. And no history of any wash basin attacks. No history of falls or any weakness of the limbs. And no history of sensory symptoms. He was able to feel mosquito bites and able to feel hot and cold temperatures well. And in September 2023, he became increasingly irritable. And in October 2023, he was asked to do simple maths by his mother from his previous 12th standard, but he was not able to do it. And he was asked to copy the notes from his previous notes. But his handwriting was not clear enough, but there was no history of writing small letters. And in November 2023, he was taken to the hospital, where in the hospital he was asked to do simple maths like 100 minus 7, but he was not able to perform it. And later he was observed to have short speak difficulties in the form of speaking in short sentences and in simplified language, and it was followed by his slurring of speech. In December 2023, he was not able to read and write and was observed to have forgotten his recent meals, what he had for breakfast, and he could not remember in his birthday, which was there in his hospital stay. And there was more difficulty in walking, and he also had pain in his both legs. Later, he had difficulty in dressing and bathing, and needed support from his mother due to increased slowness of his movements. And there was history of decreased sleep. And her mother also complained of uprolling of eyes, and he was not responsive at that episode when the patient had uprolling of eyes. And there were recurrent episodes, like around 2 to 3 episodes per day, and the episode lasted for less than 1 minute. And during that episode, there was no jerky movements or no involuntary micturition or defecation. And in December 2023, he had urinary incontinence. Because urinary incontinence, if he is taken to the restroom, he can void, but there is history of dribbling of urine. And there is no history of excessive sweating or palpitations. In Jan 2024, he had involuntary posturing of his both limbs, which was persistent throughout the day. And there was no history of falls, no history of hallucinations, and was able to recognize the colors. And he has no history of any trauma or any neck or backache. And there was no history of any decreased appetite or any weight loss. As he was gradually worsened during the admission in the hospital, he was admitted in Jan 2024. So we could not get more cognitive history. Coming to past history, he's a known case of vaginous granulomatosis. He was diagnosed with C-ANCA positive in 2020. He initially had bleeding from his right ear and cough, that is cough with hemoptysis. Then he was on tablet prednisolone and MMF 500 mg BD. And he also received 5 cycles of plasma exchange, and 7 doses of rituximab were given to him. The last dose of rituximab was in December 2022. And there was no history of diabetes, hypertension, coronary artery disease, asthma, or TB. And he was fully immunized according to National Immunization Schedule. Personal history, he takes mixed diet. He is not an alcoholic or smoker. Family history, he was born out of non-consanguineous marriage and he was born out of normal vaginal delivery. He went to high school and he had got distinctions in his board exams. This was a summary. In 2019, he had bleeding from his right ear with cough with hemoptysis. So he was taken to hospital, diagnosed as vaginous granulomatosis. That is, he had C-ANCA positive, was started on immunotherapy. Since May 2023, he was observed to be having tired and having low energy. From June he went to UK. Then he was returned to home because as he was disoriented. And in August to December, he had rapidly progressive cognitive decline. And in Jan 2024, he came to Apollo Hospitals, Chennai. Now I would like to invite Dr. Muthukanni sir for the discussion.
Thank you, Madhuri.
Thank you, sir.
At the outset, I would like to thank Professor Lakshmi Narasimhan sir and Professor Sudhir sir for having us today. This journey of 21-year-old young patient who had a very good scholastic performance before all these problems. These problems started just 6 months back with kind of mild and non-specific complaints in the form of tiredness. And within 6 months, when he came to us, he started having significant issues and he was having significant support for the activities of daily living. So the disease has progressed significantly in the short duration of 6 months. I'll try to localize the major symptoms. Then we'll have our brief discussion about differential diagnosis. We'll move on to the next slide. So it all started basically. So we know that he is a known case of vaginous granulomatosis and he had a significant immunomodulation history. It all initially with steroids, then mycophenolate mofetil, and then he also received rituximab. 7 doses, and the last dose almost 6 months back, like 6 months prior to the onset of these problems. The first complaint was lack of energy or lack of motivation. He was feeling tired and sleepy. Probably these complaints we can localize it to mesiofrontal lobe or the subcortical structures because they are very important for our fastness and processing. So these mesiofrontal and subcortical structures are very important. So probably it all started from either mesiofrontal or subcortical involvement, which is very soon followed by kind of disorientation, which means probably bilateral prefrontal cortex involvement. He was kind of disoriented to the place and time. Then, which was followed by he was noticed to have slowness of activities and stiffness of limbs also, which is again like maybe because of subcortical structures like basal ganglia involvement, or bifrontal or fronto-subcortical circuitry, which is producing a bipyramidal kind of presentation, which are like they are basically saying slowness and stiffness, which can be either of cortical like bipyramidal involvement or subcortical basal ganglia involvement. Then he was noticed to have language problem in the form of decreased word output, and which is very soon followed by he was even unable to copy, unable to write. So probably there is definitely a language involvement, which we generally localize it to dominant frontal lobe, like motor speech area, and there was some difficulty in comprehending also, which we will localize to the dominant posterior temporal lobe, that is Wernicke's area. In the meantime, like within the span of 1 or 2 months, he was noted to have difficulty in calculation also, which is localized to the dominant parietal lobe, left parietal lobe involvement. He was also had significant difficulty in dressing. So which means he also had dressing apraxia, which is localized to the right parietal lobe involvement. And finally, like following all these involvement, he also noted to have probably recurrent episodes of brief seizures, which are kind of we are not able to localize it because which was just uprolling of eyes without having any stiffness or involuntary movements of any part of the body. So probably it's like bilateral circuitry got involved, maybe cortical followed by subcortical involvement. And he also noted to have posturing of both upper limbs at a later part of the illness, which again indicative of subcortical structures like basal ganglia involvement on both sides. So the disease basically probably started anteriorly, probably like mesiofrontal or the subcortical cortico-subcortical circuitry, then which rapidly progressed and involved the parietal lobe and then temporal lobe. The occipital lobe is relatively spared, so it's predominantly a diffuse process we are having, which started with anterior, then involved the temporal and parietal lobe also, with significant subcortical structures involvement. So this is how the disease evolved. We'll go to the differential diagnosis now. Next slide, please.
Yes, sir.
We know that he is a known case of Wegener's granulomatosis. The two important differentials which we initially kept was, the first one was autoimmune encephalitis, because he's already a known case of Wegener's, so it's very much possible that he can have autoimmune encephalitis. We know that which can rapidly worsen, and he also had seizures. These are the points favoring autoimmune encephalitis, but the points against autoimmune encephalitis was the Wegener's granulomatosis was kind of significantly controlled with an aggressive immunotherapy. So when he was, when that primary disease was significantly controlled with all these immunotherapy, it's very kind of less likely that another immune process which will suddenly come up. So that is negative for autoimmune encephalitis. So Wegener's, we know that it can also affect the CNS part, so it can produce secondary CNS vasculitis, which can very well rapidly progress. And again, the negative or the odd points for secondary CNS vasculitis because of Wegener's is not like he's like a stepwise or stroke-like episode, which we would expect in vascular dementia. It's not like that. It's very rapidly and progressive neurological problem. But again, like Wegener's granulomatosis is significantly controlled with immunotherapy. So again, how come it will involve CNS to this extent in a very rapid manner? That too, within 6 months, he has become dependent for all activities of daily living. And the third differential we kept was progressive multifocal leukoencephalopathy. The points favoring was he was significantly immunosuppressed, that too with rituximab. So it's very much possible that a disease which started from predominantly cortical and subcortical structures involvement. PML is very much possible, which can also have a very rapidly progressive disease course. But generally, seizures are rare in PML. So that is slightly odd for PML. So these are the three main differentials we kept during the initial discussion. And the other differentials which we considered were the next slide. Because he was significantly immunosuppressed, any cause of chronic meningitis like tuberculous meningitis, which is very common in India, and fungal meningitis, or in fact HIV. So these infections are very much possible. So these also we need to consider. And there is definitely a treatment option for all these conditions. So we'd like to rule out all these problems. And other treatable causes of rapidly progressive dementia like vitamin B12 deficiency, copper deficiency, and Wilson's disease, they can also present. Wilson's disease, definitely it would be a worthwhile consideration because the patient had, other than the cognitive decline, he had significant subcortical structures involvement in the form of posturing, slowness, stiffness. So it's very much possible. Because of the young age, we thought of some mitochondrial encephalopathy also, which can also have rapidly worsening cognitive problems. Other differentials like rapidly progressive leukodystrophies and CADASIL. CADASIL also we thought, but generally it's a disease of middle age, above 40 and 50 years of age. Generally, they will present in that age group. Generally, they will have this vascular presentation, like a step-by-step progression. And NBAA also we thought because of the bilateral basal ganglia and subcortical structures involvement, that is also a worthy consideration. And celiac disease, another possibility we thought because of cognitive decline and basal ganglia involvement and the seizures, they are also possible. But in celiac disease, the patient never had any gastro-related complaints like loose stools, watery diarrhea, and those things. And generally, they will have posterior cortical involvement, like occipital lobe is very much commonly involved in celiac disease. But the patient history was relatively sparing occipital lobe. So they are the odd points for celiac disease. So these are the differentials which we thought probably of worthy consideration in this patient. I think I stop with this, and I ask the other panelists and other consultants, is there anything we need to consider at this stage? Thank you.
Thank you, sir.
Dr. Muthukani, one quick question.
Yes, sir.
What are the things? I mean, his B cells were completely depleted by a very aggressive immunotherapy 6 months prior to the onset of this illness. What does that? Do you think it has a contribution towards this illness? A patient who is completely B cell depleted, because all of us know that the CD20 is marked by the rituximab and then completely killed. The entire CD20 population is killed by rituximab. See, what do you think? What do you think that does that have any impact on this disease?
Yes, sir. We thought like because of immunosuppressed stage, because he not only received rituximab, he received steroids and mycophenolate mofetil also for quite some time, because he was on immunosuppression for almost 3 years completely. So it's very much possible that's why we thought the infectious possibilities as one of the important consideration, other than the autoimmune and secondary venous vasculitis because of vaginous. So we'd like to definitely rule out these infectious possibilities before proceeding further.
I mean, that's why I thought that it should be definitely on the first top 4.
Yes, sir, definitely.
Thank you. Thank you.
Thank you, sir.
I think if there is no other suggestions, I think we'll move on to the examination.
Please go ahead. Please move on. Thank you.
Yeah. Thank you, sir. Thank you, sir. So coming to general examination, the patient is alert and he is irritable and his vitals were normal and his cardiovascular system, respiratory system were normal. Per abdomen examination, there was no organomegaly and it was soft. CNS examination, he is a right-handed individual. He was disoriented to time, place and person and he is irritable. His MOCA was 9/30. Naming, he could name only lion and camel. And attention, reading the digits forward, he could do it. Reading the digits backward, he could not do it. Serial subtraction, he could only do 100 minus 7 correctly. And language repetition, he could do, and the fluency was 0. And abstract thinking, he could able to tell correctly. And orientation, he could only tell the month correctly. His GCS was 14. He was disoriented to time, place, and person. Speech was spontaneous. Speech was restricted to monosyllabus, and he has hypophonic speech. Naming, comprehension, repetition, reading, writing were all impaired. And his pupils were 2.5 mm bilateral, reacting to light. His fundus was normal. Other cranial nerve examination was normal. His bulk was normal. Tone, he had hypertonia, that is spasticity in all his 4 limbs. Power is 4/5 in all his 4 limbs. And DTRs, jaw jerk is brisk, and all DTRs were in all 4 limbs were brisk, and ankle clonus was present. Anal reflex and tone were normal. Bilateral plantar was extensor. Sensory system, touch pinprick sensation was normal. Joint position was grossly normal, and vibration was intact. Romberg's was negative. And cerebellar signs like there was no nystagmus, no cerebellar speech, and finger nose test was negative. There was no neck stiffness, and the gait was wide based. Primitive reflexes like rooting reflex, palmomental, and gasp were present. Cortical sensation, he could not able to tell properly. This was the video of our patient. He has a wide-based gait. And posturing off is both the upper limbs, probably due to due to stiffness, and the high wide-based gait we would like to attribute to the frontal gait.
So he's having this significant dystonic posturing also, both upper limbs.
Yes.
I just, for the sake of postage, just want to add one thing here. The upper limb. Look at the upper limb posture. In Wilson's, invariably the patients used to take the upper limb backwards. The shoulder will be extended, and you will see when you observe it. I have observed for all these years. The shoulders here it is forward. In Wilson's, if you look at the upper limb, it will always be backward. If you look at the shoulders, the elbow, they keep it behind the body. The upper will be behind the body, not in front of the body. Thank you. Go ahead. Please continue.
Thank you, sir. So now I would like to invite Dr. Vijay Shankar sir for the discussion.
Thanks, Dr. Ellen sir, for inviting us to this. Sudhir sir for inviting us this session. Dr. Madhuri, do you know what all the structures are involved in this patient?
Yes, sir. Yes, sir. First of all, I would like to localize in the orbitofrontal lobe because there was decrease in motivation. And then I would like to localize due to the gait difficulties and the severe spasticity, the frontocortical, frontal and subcortical structures to be involved because of the significant spasticity. And also due to the both bilateral parietal lobe, I would like to localize, sir, because his calculation was decreased, and the temporal lobe also, sir, because medial temporal lobe, the facts his birthday, he could forget his birthday, and the recent memory also he forgot what he had for the food and all. And on examination, he predominantly have the dystonic posturing and the wide-based gait that I would like to localize to the mostly to the high frontal gaits, and the spasticity to the fronto subcortical regions, and the dystonic posting, I think mostly due to the spasticity, that is subcortical involvement, sir. Yes.
Okay.
Occipital lobe, I think it is relatively spared, sir.
Spare. So overall, you see, we feel that it's a frontal, subcortical, as well as parietal and temporal region, and it is a
Yes.
subacute onset.
Yes,
Overall,
sir.
we have discussed, Dr. Muthukani has shown lots of differential diagnosis. It's subacutely slowly progressing, like within subacute also within 6 months to 1 year. So what
Yes.
all the differential diagnosis, because we have discussed about a lot of differential diagnosis, like a
Yes, sir.
vascular, infective, what all the differential diagnosis you are thinking here?
At this point of time, because he is severely immunosuppressed, I would like to rule out infective causes, like CNS tuberculosis, syphilis, and because he is severely immunosuppressed, I would also like to rule out the fungal conditions also, sir, and also syphilis, neurosyphilis, sir. Then after that, he already had autoimmune condition. I would like to rule out the autoimmune encephalitis and CNS vasculitis parts. And because there is no toxin exposure and I would also like to rule out the metabolic causes, sir, like Wilson's and NBIA, sir. And I would like to also rule out in the Niemann-Pick disease also, sir, because of the cognitive decline and the dystonic posturing, sir. And because of his gait, I would like to rule out the autoimmune causes like spinocerebellar ataxia 17, which has spinocerebellar ataxia 17 and 3, sir. Rarely rarely I would like to rule out the paraneoplastic conditions also, sir, because he was already had Wegener's. Yes.
Yeah, I appreciate it. Out of these, which one do you think is more common in this patient, in your patient? Give me some option like 1, 2, 3, 4, 5, something like that.
Yes, sir. Firstly, I would like to think in this particular patient. Firstly, I would like to think about CNS meningitis, chronic or CNS meningitis, like mostly fungal or TB, sir. And secondly, I would like to think about autoimmune conditions, sir. And thirdly, I would like to think about the CNS vasculitis, sir. And because of his spasticity and the posting also, I would like to keep in mind that Wilson's and NBIAs.
So I agree with you here. The fungal, because it's a slowly growing, almost 6 months to 1 year, the fungal is less likely to be in fact infection. Like I agree with tuberculosis is more common. For the PGs,
Yes.
just for discussion's sake, like somebody, because in a patient who has a dystonia with ataxia or cognitive decline, we always think about first as a Wilson's disease. Next is Niemann-Pick. Wilson's can present like anything, any disorder, like it can present like a dystonia, tremor, or it can present with ataxia, any movement disorder, it can be present. First, you should consider about Wilson's. Like Niemann-Pick, usually Niemann-Pick can present with a dystonia and cognitive decline, but usually they will have a upward gaze restriction can be there. And plaque D, like a NBAA, PLA G26 is one of the commonest which can present with ataxia and cognitive decline. Sometimes rarely we see a DRPLA and gluten also can present like this. And seizures, she also had a seizures. In that case, we think about in a like ataxia, dystonia, seizures, like a Niemann, same differential diagnosis like Niemann-Pick, NBAAs. At the time only SCA17, because you are told that it has a autoimmune, it usually we will think about a degenerative disorder. And ataxia with spasticity, we also think about something called as a TUP4. TUP4 is ataxia, dystonia, spasticity can also present like this. So we're coming to this, like when he is having already a Wegener's disease and also he is on treatment, I agree that it could be a CNS vasculitis, could be the first one related to the Wegener's, or it could be a neuroinfections. Metabolic, it's a slow process, like it is less likely to be. Neurodegeneration, NBAS is very, very possible because slowly progressing gait disorder, it started with gait, cognition. Usually NBAS like a PLA G26, probably it is a two types of presentation. When it is early onset, like a childhood onset, the presentation will be usually a rapidly progressive. But when it is on an adult onset, usually they can have ataxia, cognitive impairment, and sometimes they can have also this type of dystonia. But usually these late onset present disorders can usually present slowly. And also the other possibilities, like as Dr. Muthukani has told that a B12 deficiency can be there, which is a treatable disorder, but it is this type of slowly progressive is we see often, but we should keep it in the as a differential diagnosis. Also in a younger patient, we should think about leukodystrophies, usually start in the anterior, slowly progressing to the backside. So like Alexander's or metachromatic leukodystrophies also, we should think about it. And like a PML also, we should think about it, but it's a slowly progressive because of he was all treated with rituximab. Yes, there is a possibility is still there. Anything else do you like to think about it, sir?
Just, I would like to say a few things. The points which are against this infectious possibilities. This boy has never had any systemic complaints in the form of fever, headache, vomiting, because you would expect that in TB or TB meningitis, or in fact for fungal or any meningitis, generally we would expect this fever, headache, vomiting. Maybe because he is immunocompromised, we might not have developed a fever. But because of this absence of systemic complaints is one of the strong negative point for having a active infectious process. And this history is kind of very rapidly progressive. Within 6 months, he has become completely dependent for his activities of daily living. So all these degenerative causes of this dementias are definitely very, very less likely. Other than what we discussed, I think infections, definitely a worthy consideration. Autoimmune encephalitis, secondary CNS vasculitis because of Wegener's. I think these are the common differentials I think we can consider. And PML obviously because of this.
Yeah, PML, yeah, obviously. Sir, Arul sir, Ilan sir, Sudhir sir, do you want to give some valuable points to somebody, sir, the students?
No, it's excellently discussed by both of you. I think we should go for investigations.
Thank you, sir. Summary, he's a 21-year-old gentleman. He was brought with insidious onset and gradually progressive dementia with bipyramidal tract signs, sidely dystonic posting of both upper limbs, and seizures with no sensory but doubtful cerebellar involvement. So coming to investigations, his chest X-ray was normal. And the routine investigations like WBC count, hemoglobin, and his random blood sugar were normal. His vitamin B12 levels were normal. And his thyroid profile was normal. And his serum electrolytes and serum ammonia were normal. ECG had shown the sinus rhythm, but 2D echo showed the global hypokinesia with left ventricular reduced left ventricular ejection fraction, that is 35%, and his liver and renal function tests were normal. His viral markers like HIV, HBsAg, and anti-HCV were negative. ESR was normal, CRP was normal, and his serum RPR for syphilis was negative. And dengue serology, MPQPC, Leptospira sceptifus, and respiratory viral panel were all negative. And the serum ceruloplasmin levels and copper studies were negative. And the CSF analysis, the protein was normal, glucose was normal, and the cells were only 3, and the differential count was all lymphocytes. Meningoencephalitis panel was negative. Expert MTB was negative. CSF VDRL was negative. Anti-MOG NMO antibodies and oligoclonal bands were negative, and the paraneoplastics panel, both in serum and CSF, was negative, and serum autoimmune encephalitis panel was negative. Anti-CD20 antibody we have done because he is on rituximab, it was negative, and the vasculitis panel showed DNA was positive. ANCA and ANA was negative, and HLA-B5 and 51 were negative, and the extended ENA panel was negative. Serum ACE levels were normal, and the complement levels were negative, and anti-endomysial antibodies were done to rule out the celiac disease. They were negative. This was his MRI brain showing diffuse bilateral symmetrical volume loss, and also showing periventricular hyperintensities and some diffuse hyperintensities. And his MR angiography was normal. Perfusion scan showed diffusely reduced perfusion, and his contrast was normal. MR spectroscopy was done. It showed altered Hunter's angle, that is, it showed increased myoinosol peak, which was suggestive of sclerosis. This was his EEG. It showed diffuse slowing with frontal predominant sharp waves. This showed the generalized slowing with intermittent delta waves. They showed diffuse generalized slowing with intermittent frontally predominant sharp waves. CT chest and abdomen were done. CT chest showed a thin-walled fibrotic stance, and CT abdomen was normal. His PET scan was essentially normal. So here I would like to invite Dr. Arul Selvan sir for the discussion.
Yes. So we had a few differential diagnosis at the end of the examination. So we tried to either rule in or rule out the possibilities. So one of the things high in the card was progressive multifocal leukoencephalopathy. So the MRI clearly rules out a progressive multifocal leukoencephalopathy because it is a highly MRI positive characteristic picture. So here the MRI is highly non-specific. So it shows some diffuse cortical atrophy. There are few hyperintensities, mainly in the subcortical, almost the U fibers. At that level, there are some small patchy hyperintensities in the T2 and flare. And periventricularly also, there is a very thin rim of hyperintensity. So the MRI is not diagnostic of any particular either a gray matter disease or a white matter disease, nor there any definite features of infections like tuberculosis, meningitis, or herpes encephalitis. There is no features to suggest something like a CJD either. So there is no features of vasculitis. There are no infarcts seen. Mainly we see some mild confluent periventricular hyperintensity and U-fiber hyperintensities, but nothing suggestive of a vasculitis either. So the MRI is a non-specific, and it rules out a few things like progressive multifocal leukoencephalopathy or a florid multiple sclerosis or acute disseminated encephalomyelitis. So all those things seem to be excluded. So coming to CNS infections, like the other thing we were thinking was whether it could be some sort of a chronic meningitis, tuberculosis, fungal meningitis. So CSF is essentially normal. So it rules out the possibilities of a bacterial meningitis or tuberculosis or fungal meningitis or a herpes encephalitis. Of course, the other possibility of autoimmune encephalitis, because the patient has prone for autoimmune disease. So the CSF autoimmune encephalitis panel is negative and the serum encephalitis panel is also negative. So even though this negative may not 100% rule out autoimmune encephalitis, the MRI also is not typical or suggestive of autoimmune encephalitis. So that possibility looks rather remote. And we were also thinking of whether it could be some sort of a paraneoplastic disease, because the patient was on a lot of immunosuppression, some malignancy paraneoplastic. So the PET-CT is also normal. So at the end of the investigations, we have not found anything to go in favor of an immune-mediated disease of the brain. And we don't have any definite indication for any infection of the brain either. So metabolic problems, sometimes rarely rapidly progressive leukodystrophies may present with a rapid cognitive decline, but nothing to suggest a florid leukodystrophy was found in the MRI either. So very rare diseases like, say, Whipple's disease, some atypical infections, some query of these things are there. So at the end of these investigations, practically we have drawn a blank. Right now, I would like to invite the other faculty members to give their opinion at this stage, what they would like to consider as a diagnosis with all these things being negative.
I'll just add a single thing. Because we were considering a kind of immune-mediated process for him from the first day, we have treated him with 5 days of methylprednisolone, followed by a course of IVIG. So he was here for almost a month in Apollo. But following this steroids and IVIG also, there was no significant improvement. In fact, he was like going down day by day. So that maybe again may not be favoring a kind of immune-mediated process in the brain.
So I think can you just repeat the exact visual findings? What is the problem of vision and what is the fundus looking like?
Vision, he did not have much problem, sir. His fundus was normal, sir.
Okay. As such, doctor has run one short slide, a quick slide, and probably that has cleaned the diagnosis. I think I should not speak directly because it shows the diagnosis. I think you showed an EEG slide, right?
Yes, sir.
Yeah. So that has been discussed, because in between I lost the connection. So I'm not sure whether the EEG has been discussed or it is pending.
EEG has been discussed, sir.
So can you show me that again, please?
Sure, sir. EEG, it showed diffuse slow waves, sir. with frontally predominant sharp waves, sir.
But these are periodic and superimposable? Just show me further then.
Yes. There is a diffuse slowing, sir, with intermittent delta, sir.
Yeah, so maybe there is some degree of superimposability here, as I see. Right. And didn't have myoclonic jugs, did he?
No, sir, he don't have, sir.
Right. So diffuse slowing with periodic deltas, and some of them are classically superimposable. Show me more pages of EEG, please.
Yes, sir. This is the another EEG, sir. It showed a diffuse slowing with frontally predominant sharp waves, sir.
Yeah, I think I know the diagnosis. Okay, thank you.
Thank you, sir.
Dr. Lakshmi, are you there? Professor Lakshmi?
Yes, sir. Yes, sir. So I think here with in the background of Wegener's, which been there, and I would have definitely gone in for meningovascular biopsy, sir.
Yes, sir.
Actually,
because
we
the
had
adequate
offered
trials
the-
have been given, adequate drug trials have been given. There's not much of improvement. I think our next step should be to go in for a meningovascular biopsy.
So we have
Thank-
offered this, sir, the
Yes, sir.
biopsy to the patient, but the parents refused biopsy. So one of the reason was he also has because of the Wegener's, he has got a myocardial involvement. So he has got a
Yeah,
ejection
that 38% ejection fraction, which we have not discussed.
5%. Yes, sir.
Yeah,
Yes, sir.
that we have not discussed.
Yes,
And
sir. So he had a Wegener's related problem. He had a myocardial involvement with a lower ejection
Does
fraction.
Wegener's involves myocardium?
Yes.
How common it is when I'm not. And secondly, the presentation is aortic Wegener's. No, it's not the sinus form. It's the aortic form. Looks like from whatever you said in the initial one, you know.
Yes,
He
sir.
had epistaxis also, sir. He had a
Oh, yeah, it's epistax. Okay.
predominantly he
Epistaxis.
had involvement of the sinus and the ear.
Both.
And he also had cough and hemoptysis.
Cough
also
and
he had.
hemoptysis also he had, sir.
Lung involvement
Okay.
also he.
Okay.
Yes, sir.
Okay.
And
Yes.
so it's a rapidly progressive dementing illness in an adolescent child with this kind of EEG and other features which you have mentioned, text and all that. What is the status of measles and antibodies?
Yes, sir.
You have hit the nail on its head, sir. Now we will present the further things, sir.
Okay, please.
So we have done measles antibodies, sir. CSF measles antibodies. The ratio was positive, sir. Actually, the positive range is greater than 1.5, sir. Our patient had the time 1.58, sir. It was done in Metro Plus, sir.
Wonderful.
Metro.
So there is a history of measles in childhood, or there is no such history?
No, sir. No, sir. He don't have any history of fever or rash in the childhood, sir, and he was fully immunized, sir.
All of you
Yes, sir,
are agreeing with
proceed.
the diagnosis, sir, of SSP in this case, sir, or any other suggestions or anything else which we can.
Wegener's is slightly confounding factor here, but looking to these measles, the history, short, rapidly progressive dementia in adolescent, the way you showed the video and the EEG, and I think evolution of EEG will come over few more weeks, and I think you are reasonably justified in thinking of slow virus disease, particularly, I mean, primarily SSP, and probably history of measles may be misguiding. They may not give properly. That's okay. Dr. Lakshmi, what is your thought on that?
Sir, in fact, I have seen. Hello?
Yes, sir.
Yes,
Hello,
sir.
can you hear me? I have seen a similar patient in a young girl, +2 girl, but almost similar. We are not sure, and then it came as SSP positive. We started on alpha interferon, sir, intrathecal. We use that the brand which is alpha interferon, which is commonly used by the gastroenterologist. We use that alpha interferon intrathecally. To my surprise, she improved, sir. Still under, she's in fact weekly alpha interferon intrathecal. And there's one in Calcutta. There was a neurologist who has done a similar study with alpha interferon using a Somaya reservoir, where you don't have to puncture the. But here we gave every week. Our residents gave, and the girl started coming. She was completely wheelchair bound, and I could see some improvements, sir. I don't know whether you have tried, sir.
Actually, the patients told they'll get it done in their hometown, sir.
But it is definitely useful. I have found.
Yes.
In fact, I never thought that alpha interferon could, SSP could reverse so much with alpha interferon. I am really convinced that it has got a. I'm convinced that it definitely gives some useful return of their life. Thank you for a wonderful case.
Thank you, sir.
Sir, anyone has any experience with levamisole for SSP, sir? We have tried in a patient who had very significant problems because of SSP. He had rapidly progressive dementia along with typical slow myoclonus. We put him on levamisole and he improved significantly. I have a follow-up. Maybe in the another meeting we can discuss that case. He just improved like anything. The dementia has like almost 70% improved. His myoclonus completely stopped, and he started going back to school. Anyone has tried levamisole?
We have not tried. I don't know. We have not tried levamisole, but the alpha interferon is what which is, and this what is this inocytin, that one which is very rarely available. Most of the times you try for what is the drug which we commonly, which is
Isoprenosin.
Hardly available. Isoprenosin hardly available in the, most of the times the people not available in the market. Anyhow.
So many people use many antivirals, lamivudine and this and that. But in my experience, thoroughly the disease is fatal in 98% cases. However, some surprisingly have some immunological sudden shift of the immune system and they improve spontaneously. I don't think, I can't say that it is particularly because of this drug or that drug. But in my 35 years of career span, I have at least memory of 5-6 cases of confirmed SSP who have recovered and gone back to work, school, etc., survived, and one case has again relapsed at the age of 33. I know with the name also. So this is because of some kind of immune system regulation of its own. And some people have done well with this intrathecal interferon business. And I think Dr. Udani has a great experience in Mumbai. He had done a lot of studies. But the recovery was not that significant in most of the cases as per my personal communication with him. Some people do little better for a few months and then again they lapse. So I am not very sure whether there is any real drug that helps or but there are some cases who have spontaneous remission or some other reason why they have gone into remission, and maybe some drugs might have played a little role here and there. But even people have tried immunoglobulins, these, that, steroids also long term, but I doubt whether they really work. That's what my take on this. But it's an interesting case, very, very interesting, and till last, the secret is there. So it's a real secret of neurology. Our compliments, Dr. Selvan and Dr. Vijay Shankar, Muthukani, and Dr. Madhuri for presenting this.
Sir, my hearty thanks to the entire team from Apollo.
Thank you, sir.
The Dr. Arul Selvan, Dr. Vijay Shankar, Dr. Muthukani, and Dr. Madhuri.
Thank you,
And
sir.
the excellent case. I'm sure that everybody would have enjoyed. You kept the silence until the last. And you know, as you see, Professor Sudhir Shah with his vast experience, and well, he immediately nailed it on looking at the EEG. I'm really very happy. It was a very good session, and thank you so much for everybody. And I hand it over to the organizers.
Thank you, sir.
Thank you very much, sir, for the opportunity given to Apollo Chennai to present a case in this August forum. Thanks to
Yeah,
Professor
we
Sudhir.
were waiting for Apollo Chennai to participate. So keep your cases ready, and in the second turn you will have another case to present, please.
Sure, sir. You're welcome, sir.
Thank you
Thank
very
you.
much.
Thank you so
Thank you, sir.
much.
Thank you very much, sir.
Thank you, sir.
Thank you, sir.
Very good evening, everyone. Today marks a remarkable milestone as we celebrate the completion of the 44th episode of Secrets of Neurology. On behalf of Entas Pharmaceuticals, I, Shweta Chandrakar, extend my heartfelt gratitude to all our esteemed delegates for accompanying us on this significant journey over the past 44 months. I extend my sincere thanks to our honorable course directors, Dr. Sudhir Shah sir and Dr. Lakshmi Narasimhan sir, for crafting such an exceptional web series on neurology, which has proven immensely beneficial to DM and DNB students. Our appreciation extends to Dr. Madhuri Sharma for her insightful case presentation and Dr. S. Muthukani sir for his meticulous evaluation of symptoms, investigation, and literature review. Special thanks goes to Professor Dr. Vijay Shankar sir and Dr. Arul Selvan sir, Senior Consultant Neurologist at Apollo Hospital, Chennai, for generously sharing their invaluable experience with this case and providing crucial learning points. Once again, I extend my sincere gratitude to each one of you for your gracious presence. It has been a pleasure being with you all on today's episode of Secrets of Neurology. Thank you for your presence, and we eagerly anticipate meeting you again on 29th March 2024 for next awaited episodes. Till then, have a great weekend. Thank you so much, sir.
Thank you. Thank you very much.
Thank you. Thank you, sir.
Thank you, sir. Thank you
Thank
for
you,
giving us
sir.
the opportunity.
Thank you, sir.
Thank you so much, Vijay sir.